So we'll start with the orthopedic panel. I'll ask them to turn on their videos. Dr. Garg, Dr. Laughlin, Dr. Bobby, and Dr. Ward. And we start by just briefly introducing yourselves to the audience. So, is Dr. Garg on? Guess he didn't make it. Dr. Punch Bobby.
Hey, how are y'all doing? Sorry, I'm a couple of minutes late here joining in. Very delighted to be here. Happy to share my experience in orthopedic surgery and why I got in here and so on and so forth. Currently, I'm in academic practice at University of Texas in Galveston. I'm a professor in orthopedic surgery. I do subspecialty, which is the foot and ankle subspecialty in orthopedic surgery. And I've been in this role for past 20 years. And we have residents and fellows, and we interact with medical students and even high school students interested in orthopedic surgery. I'll be happy to share what all my experiences, any questions. Happy to answer any questions. Thank you, Dr. Yang.
Okay, Dr. Laughlin.
Hello, my name is Rick Laughlin, and I'm at the University of Cincinnati. I've been in orthopedic practice for about 27 years. I started in Texas, and where I went to medical school, and then migrated to the Midwest. I also do foot and ankle surgery, so make sure we don't narrow our view too much. Orthopedics is a very broad field, and I think we'll both try and speak to that. My practice is based mostly in trauma and reconstruction, and it's a academic practice as well, and keeps us very busy. And I think the main point I would give you is a very broadly expanding field with expanding surgical indications and many opportunities. So I'll be interested to answer any questions later on.
Great, thank you. Dr. Ward?
Good evening, folks. Bill Ward in Winston-Salem, North Carolina. I've walked on both sides of the academic private practice field. I was in academics at Wake Forest University, where I was a professor for 22 years. And then I was chief at a little place up in Pennsylvania, the Guthrie Clinic. And then 7 years ago, I started a private practice here in Winston-Salem with Novant Health. So it's a big multi-specialty group. I came to orthopedics. I thought I was going to be a general surgeon. And then during my internship year, I had a month on orthopedics, and it was just so much fun. I never looked back, and it's been great. Trained at Duke and did a couple fellowships, one in sports medicine at the Cleveland Clinic. And then I felt a need to do something a little more different. So I went to UCLA, and I now have a practice in orthopedic oncology, and I've been treating bone tumors my entire life and doing a lot of hip and knee replacements as well. And I still do some total joints, still do some sports every now and then, but not many. So that just my own practice shows you the breadth of orthopedics. We do hips and knees. We do them as adults. We do them as adolescents. We do them as athletes. We do them as kids with congenital problems. So they're pediatric orthopedists. We do hand, we do spine, we do shoulder, elbow. Orthopedics is a great field. I guess you can sort of tell my enthusiasm. I'm 68, working hard, loving every day, and I look forward to every day going into work. Happy to take any questions.
Well, you don't sound like a day over 50.
I still water ski and wake surf.
Okay. Let's see. Actually, getting some questions popping up, which is great. So there's a question about the benefits of doing a research year between your third and fourth year. Is that very helpful for an orthopedic residency application, and what would a competitive applicant look like?
Well, in this day and age, I was on our residency interview committee for a number of years. Think of it this way. each program is looking to train great orthopedists who are then going to represent them in the world. And if you have something that makes you a little bit different, you have a little something extra to offer, it's going to make you a little bit more attractive.
I will second that. I think, I've been helping the residency committee at my university for many years. And over the years, I've seen increasingly, applicants are getting very, very competitive. And initially the interest, going back 10 years, folks who want to apply into orthopedic residency used to get interested in their fourth or fifth year and maybe dabble a little bit in a case reporter and so on and so forth. But increasingly over the years, students are getting involved from get-go, year one, year two, and by the time they have the applications in, they already have at least one or two, but doesn't mean that that's the must. There's a whole lot of things that goes into considering a candidate. Not everybody we are trying to get into orthopedics will end up into research, but certainly, as Dr. Ward mentioned, anything you can do to improve your application, be it serving on committees, be it research, be it in other areas, performing well on your rotations and so on and so forth. Every little bit helps. Even the scores can help, and performance in the interview also. So it's a whole package. Certainly you can add the research bit to it if you can and want to.
The main thing I would add to that question is that I think one of the problems that subspecialties have is that medical students don't get a lot of exposure to that area. And so, oftentimes your exposure to orthopedics may be very limited. And I think doing some research in it gives you an exposure and lets you know a little bit more about what you're getting into. And so I think when you go through the interview process, one thing we want to see is that people at least have participated in orthopedics and seen what it is they're trying to get into. And so research does that for you. And the last thing I would say is that with we're getting rid of the scoring on part one of the boards. And so that's one thing we used to always look at. And so again, you have to have a little something that differentiates you that people can want to explore more and interview about. So research helps in that way too.
Definitely, I agree with that. The question was, should you take a year out? I don't know whether it's absolutely necessary to do that. But I say, if you're, as soon as you are sure that you want to pursue orthopedics, I would suggest, find out folks nearby in your institution from the orthopedic department, see who is doing research and get involved as soon as you can, and perhaps, join their clinics or OR and make yourself familiar in that program or nearby programs. And that way you get to know about the field, and the folks will know about you as well. And then you have established an interest in orthopedics, and that you can portray that in other places you interview.
There's a few questions, perhaps starting a little bit more broadly. We all know that you match into an orthopedic residency directly from medical school, but are there different types of training paradigms? How do you know early on that you want to do ankle and foot, or you want to do oncology? Is it difficult to sort of give a subspecialty early in your orthopedic career, or even when they're asking you questions during the residency interview?
I don't think it's that important to know what subspecialty you might pursue early on when you're interviewing. I think most residents and most residencies give you a fairly broad exposure in your first 3 years. And most residents, if they're going to do a fellowship, are deciding on that around the end of their 3rd year or 4th year. And then they try and direct their activities to support that. So I don't think it's necessary to know the subspecialty, but
I concur. Yeah. I think, getting into residency can be as broad as, as possible. And then residency will change your mind. Sometimes you might have some specialty already worked out, or you might start off having no clue and then, evolve as you do your residency. So that's not a problem.
There are a tremendous number of applicants are interested in orthopedics because they had some kind of sports injury growing up, and that's the orthopedist that they know. And so there's a huge number that say they want to be sports doctors, and some of them go on to do that, but a lot find another subspecialty equally or even more attractive. I'd say more come in uncommitted than come in committed to a subspecialty.
I would agree with that.
Are there ways to subspecialize during your general orthopedic program, or everybody pretty much does the same thing as they march through their orthopedic residency?
Most people do about the same thing.
Yeah.
They may, it's a set of rotations and most everybody does all of them. And the folks who are interested in the joint somehow end up scrubbing on more joints than anything else. And the ones who are interested in spines scrub more spines. And the ones who are very disinterested somehow aren't there as often in their senior years. So
they tend to differentiate in year 4 and 5. So, they have to maintain a logbook. The requirements are there, so you have to go through every subspecialty, and there is a curriculum the residency has to follow. But Dr. Bard is right. Towards the end, once they become interested, rooting for a subspecialty, they show more interest. They are looking for a fellowship program sometimes, and they pursue that.
So, a little bit more about the application process. There's some questions on, what if you get a high pass versus honors? Is that, maybe is that a death sentence for applying for orthopedics, or what are some other areas other than research that you would suggest to try to make yourself to stand out?
I did briefly touch upon it, so, if you are interested in a program, certainly you can get a rotation out, in a couple of places you're really interested in, finding more about the residency program, and then perform well in their rotations and get to know the faculty there, right from chairman down to program director and other faculty. I think that helps to build a rapport with that program. And if you do well, come on time, scrubbing cases, know about the cases. Those are things which can leave a good, memory of you when you leave, and then hopefully you can capitalize on that during interview program. And certainly you have to do well in the interview as well. So there are a lot of things, go into a selection process, and not just one thing stands out.
I would agree with that. I think familiarity is really important. And the more you know some of the faculty, because the way you learn oftentimes is just modeling behavior that you find similar to yours. And so I think that being familiar with what goes on a day-to-day practice, and then people are going to be able to write you a much stronger letter of recommendation if they know you well. And so I think those, again, I don't mean to keep going back to the board scores, but there are fewer objective ways for us as faculty or people interviewing you to differentiate you. So familiarity with the faculty, I think, is very important.
And some folks, if you don't match, it's not the end of the world. There are ways to get in later. And I was an ER doctor for 4 years before I went into orthopedics at Duke. They had an opening in the program the year I applied for orthopedics, and I got in. I've helped several students who did research for me for a year after their internship. And just when I was at Wake Forest and up at the Guthrie Clinic, I had several who worked for me, and I helped them get jobs in other labs. And those folks are now orthopedic surgeons. So it was a little different pathway. So don't give up.
Well, great. There's a few questions about your practice. So one is, can you just work as a general orthopedic surgeon these days? And Is fellowship absolutely necessary after you finish your residency? And other along the lines of the practice setting, can you still be like in solo practice? So if you can answer those questions.
As the guy in private practice, I will say it's difficult to do solo practice now. You have to work out a collaborative call arrangement unless you're in just a tiny little town and you're the only orthopedist and you take call every day and every night. You have to have collaborative call agreements. The hospitals will require that. And even if you start out as a general orthopedist, most folks end up with an area of interest after 5 or 10 years. There's just so much to do in orthopedics, so many different things. It's challenging to stay up to date in all the many areas. So most groups that are hiring are looking for a foot and ankle doctor, a spine surgeon, a hand surgeon, a pediatric surgeon, an adult reconstructive surgeon, a sports guy or gal. So most residents, at least at Wake where I was most recently, by the time they finished, most residents tended to do a fellowship. It's not required, but they tended to do it. And it helps them get the job they want.
I would agree with that. About just the way things are right now, over 90% of the graduating residents do a fellowship. And again, it's not required, but I do think the breadth of orthopedics is so broad that people like to hone in on one thing and one or two things and really be an expert in those areas.
Yeah, all the specialties are growing so much. It's very difficult to keep track with the advancements occurring in every little area of orthopedics. So I think you get better in one particular specialty, and then you want to practice that, and then have a little bit of general. When you're doing trauma call or something like that, so you may have to do other stuff. But I think most will gravitate to choosing a specialty or a few things they like to do most.
Yeah, I still take trauma calls, so I'm doing general orthopedics when I'm on call, and I'm washing out infected this, that, and the others, and fixing fractured this, that, and the others. But I call my partners if it's something in their field, bad proximal humerus fracture. I call my shoulder and elbow partner, and I put it on ice, and they'll fix it later that week.
So it's still important to know general orthopedics, even though you may be subspecializing in a particular area, correct?
Yes.
Yes.
Okay. Yeah, I think it's much like the other subspecialties. Yeah, you may focus on one thing, but it's important to know the field in general because A, you never know what type of job you're going to get. And B, I don't know for board certification, they still answer, they still ask those types of questions. So it's important, not to forget the field that you're in.
Well, in addition, is also call is kind of what binds us together as a specialty. So most everybody has to take some type of call. And when you're on call, you get a mixed bag of things.
So I'll ask a somewhat provocative question. So what does it mean to think like an orthopedic surgeon?
Yes. Think like an orthopedic surgeon. Yeah, there is something, you have to have that mechanical sense, you see, you need to have a sense of aim, direction, and getting things right. You want to think, there is that personality there. I must say, I come across a lot of medical students, and some you can say, wow, this guy gets it. And some, we have to be good to hands, I think so. And, and have to have that analytical qualities and some kind of a mechanical, the bone, how the screw works, and so on and so forth. Not everybody gets that, though. I think
I would agree, and I think also you have to. I mean, more and more. I ask students when they're with me, do you have a drill at home? I mean, do you ever do things with your hands? Because that's a big part of what we do, and you have to have some three-dimensional sense to be able to do those kinds of skills. And just like Vinod said, I mean, some people get it and some people don't. And so if you've been in a lab, titrating test tubes all your life, and then you start trying to use some of the tools we use, some people just don't make that transition.
There's probably a higher percentage of former athletes in orthopedics than about any other field. It's not a requirement, but it's just, it's a team sport and it's fun. You fix stuff, and it's a great field if that's what you like.
That's why I would encourage, if you are seriously considering orthopedics, get in the OR, get in the clinics and have a feel as to if that's what you want to do, if that's what you are good at doing. I think knowing that early on will help you.
And I thought I'd ask a question. There's a few questions on a very timely topic about, diversity and inclusion. Can you tell us what the field of orthopedic surgery is doing, and perhaps what are some strides that your field is making to make up for some of these disparities?
Well, our last Academy president is a gal. Christy's done a great job as president. I think we're probably the most male-dominated subspecialty, but I would say we're making great inroads in that. And I will tell you, at our Musculoskeletal Tumor Society, our presidential guest speaker was a diversity speaker, and it was one of the attendees stood up and said, "This is the best lecture I have ever heard." It was Dr. Bagley from your place, Dr. Yang, and oh my gosh, it was fantastic. And it's the wave of the future. There's more roles for women and more roles for minorities in orthopedics, just like in anything else.
Yeah, I would agree with that. I think, we are increasingly getting diverse, and there's no holds bar, and we encourage every facet, there's no discrimination as I can see. We actively encourage, involvement from every facet of the society to get into orthopedics.
So yeah, I know Christy well. I really miss her from here. She was wonderful when she was my first probably orthopedic friend that I made 20 some years ago. And sort of along the same lines, maybe you could speak a little bit about I like to call it work-life integration as opposed to balance, because there's really no balance in surgery. It's more how you weave work and your life and your home life together.
Well, I would say, mine has certainly changed over the years. As I've gotten older, and I think you just learn how to manage your practice a little bit better. And as you get a little more subspecialized, your life becomes a little more controllable. But I'm proud to say I've got a family and I have a wife, and I've been married for 29 years. And so surgery is a demanding field. Hopefully you have an understanding family and spouse, but it is manageable. Orthopedics has changed a lot over the years, such that now we operate a lot less in the middle of the night. Many things we can temporize and then just do during daylight hours. So it's not as demanding in the middle of the night as it used to be. So I think there's time, and you can certainly balance your life.
I agree with that. You choose what you want to be. If you can be as busy as you want, or you can, have more of a balance, if you will. Some people choose 9 to 5 kind of work. They go employed by hospital, so on and so forth. On calls can be busy in a very busy place, or it can be on a level 1 trauma center. But even then, like Richard says, you don't have to go in the middle of the night for many of these things, and it can be dealt the next day. And so it's less demanding these days. And again, you can be as busy on sometimes private practitioners, and they can be too busy. And maybe Dr. Ward can attest to that. And he probably has experience in ER as a ER doctor, and then orthopedic surgeon, so he can tell us, both these specialties, compare them. But I again, I have white kids, and we go on holidays and so on and so forth, and I have most of the weekends free, and most of the evenings are free, like tonight. So I'm able to spend with you all.
Yeah, I would say it has evolved. Clearly, I had more control of my life when I was an emergency room doctor. I mean, I worked a set number of hours and then I was off. It's not that way in orthopedics. As an orthopedic oncologist, I'm the only one for the entire Novant system. So it seems like I'm always on call. And, fortunately, I really like what I do. And my wife of 41 years hasn't fired me yet. And we had 5 kids and I coached their soccer. And, I had to work to get to all those soccer practices. I can tell some funny stories about doing that, but I managed to get there and virtually all their games and coach. But I mean, I had to work to make that happen. I had to make it like the prime thing, or one of the prime things. But I don't know. I was also on the board of directors of a bank for 30 years and was chairman of the board of directors of a bank. So I found time to do some other stuff.
Well, great. Well, our time's almost up, but I'm going to ask one sort of transition question. I think one of the reasons, we strategically put orthopedics with neurosurgery is who does the spine? Orthopedic surgeons or neurosurgeons? I think there's always questions, I know there's always overlapping fields.
Right.
So what's the difference?
Yeah, there's overlap, not just in spine, hand surgery. Sometimes plastic surgeons also get involved with that. And similarly spine. I think, the person who feels best at it should do it. I think, if you evolve a practice, spine practice, and you're good to do most of the spine, they do it. So, and if neurosurgery wants to, focus on the spine part of it, and if they're good at it, they can do it.
We actually recently recruited a spine surgeon a few years ago who trained at a wonderful institution, did a great spine fellowship, all in orthopedics. But when he came to Novant, he actually wanted to join the neurosurgery group and be a part of their group. And so he takes call with the neurosurgeons. And if it's, a head problem, then there's a neurosurgeon that backs him up for head stuff. But he takes spine call with them. And so he's who I typically send a lot of stuff to, but I send a lot of stuff to the neurosurgeons, and they work together. I work with them because sometimes tumors involve the spine or are next to the spine. So I'll be there as the orthopedic oncologist and they'll be there as the spine surgeon. So we work together on cases.
Yeah, I would agree. And I think that's something that it's really evolved over the last 30 years. I know when I first got into orthopedics, the orthopedic guys were the ones that put all the hardware in, and the neurosurgeons might do some of the decompression or the spinal cord work. And really over the last 30 years, the neurosurgeons have, a lot of programs have focused much more on spine. And so now they do a lot of the mechanical work or the hardware work and fusions and such. So now I think it's just a factor of where you trained, but there's definitely a lot of overlap in a lot of places they do the same thing.
Yeah, so I think, just to sort of end it, it's not so much, two different specialties, but, there is going to be some overlap. Medical students often, are a little confused about it, but as you all just heard, there's a lot of collaboration. It's really not competitive this anymore, but we don't work in silos, and there's some crossbreeding, as you heard. There's neurosurgeons working in orthopedics. There's plastic surgeons working in in orthopedics. So there's a lot of cross breeding. So